Good evening, everybody. Guys, do you hear me?
Gotcha.
Perfect. Well, first of all, I want to welcome everybody. This may sound very cliche and it may come out the wrong way, but for those of you who are aware, today is the second day of Rosh Hashanah. So to my colleague, Dr. Lehrman over here, I will wish him a happy Lishana Tova. I also think that God would be very pleased that I'm starting the new year off speaking with two of my very dear friends and educating our colleagues on how to make their practices and their lives better. So I think it's very ironic that we're giving this presentation on the second day of Rosh Hashanah. With that being said, I briefly hit on it. I really am truly really honored to be on this presentation with two people who fortunately and are I call very, very dear friends, but beyond that, I think we all have a common passion in that we've all wanted to give back to our profession. In all different ways, we have served our profession and our association in a way that I don't think many people really can appreciate or understand, but know that it's done as a labor of love from all of us when we educate you and teach you, because we want to keep you out of trouble and we want you to be able to earn a living for the work that you do. With that being said, I am going to turn the podium over to my dear friend, Dr. King, to let him tell you a little bit about Taylor Medical, and then I will come back and introduce our guest of honor. So, Mike, I'm going to turn it over to you.
Excellent. Thanks, and Jeff, welcome. It's always good to have the coding triumvirate here, so to speak, triad, whatever. And so it's exciting. So we're always thrilled that you can all join us for this. And I know you're going to find this presentation just super, as all Jeff's talks are. But I think Ira, we were just talking about this a little bit ago, because of all of you here and all of those out there who can't join us this evening, Taylor right now is killing it. That's a quote from our boss. So Taylor's killing it. We're doing great. And the reason we do great is because of the involvement that you guys have. Now, for any of those of you who have not signed up and gotten involved, this is the place to be. This is the time to do it. So we're going to talk about that a lot. I just want to remind you that on the webinar, you can go back and watch this webinar. And there's no question that when Dr. Lehrman speaks, he's like E.F. Hutton, you're going to want to listen and you're going to want to pay attention. And you can go back and be able to review this webinar again and take a look at some of these things that Jeff has. And I've seen the slides and they're very fascinating. It's going to be really interesting. But if you haven't been involved yet, please do. Please tell your friends. Tell your friends about this. This is such a big deal. Get that list of your vendors, of the products that you're using. Jeff, you're still working at, in a practice all the time. Ira and I are now old men, admin guys, and we're not in it every day like you are. And so you can feel the benefit of it every day. We can see it, and Ira and I understand the impact of it. We can see it through the metrics. You see it every day in the practice. And for all of you, it's so critical to get your information in, send it to Carla and her team, your vendor list, your SKU numbers, your sizes of products, what you're paying for these now. Put them in any kind of form you can. If you can put them in an Excel sheet, super. But get us the data so we can save you a ton of money, and it makes a big difference. And so let's get you involved. And if you're not involved, get involved. If you are, keep pumping, because right now, gang, we're killing it, and it's thanks to all of you. And so Ira and I and Jeff all want to say thank you, those of us who are participants on the board at Taylor. So Ira, I'm going to pass you back to make introductions of our illustrious guest, and looking forward to listening in. So I'm going to disappear to the side and kill it, Jeff.
Thanks, Mike. I'm going to just dovetail on one thing that Mike said. Obviously, Taylor wouldn't be here without all of you. As an organization, we are committed to giving back to the profession. We've given two $25,000 scholarships to the Educational Foundation. But I think the most important thing that people don't realize is we can be your one-stop shop for everything. Before you buy paint to redo your office, before you buy computers in your office, you need credit card processing. There has not been a big formal announcement. It will be coming one of our major partners, which was Interlear, which is where a lot of our high dollar pricing comes from, was acquired by Provista, which now owns 60% of the marketplace. Through Provista, we have free consulting services for your practice. You want to open up a new clinic? They have people that will help you design the clinic. You're building a new operating room. They have people that are going to design that operating room. And guess what? There's no charge. I know you find that hard to believe. Obviously, their goal is ultimately they want you to use their consultants, but they're here to provide a service. And Taylor is here to provide a service. That's what we're here for. There's no charge. It's no gimmick. There's no charge. You like it or you don't. Give us the opportunity to show you what we can do for your practice and what we can do for your staff. We have staff programs that are available. Anyway, I'm not gonna hold off the show anymore. People are fighting to hear Jeff Lehrman speak. They're saying, "Oh my God, the legend is on Taylor tonight." So anyway, without further ado, I remember my very first time when we met. I remember the years that we've been speaking. I remember when Jeff took a picture of me at a AAPPM roundtable and told me that it was his favorite picture of me because I was talking to residents and young practitioners. So we all pay it forward. And Jeff, I'm going to turn it over to you. I'm going to disappear and I'll come back and close out when you're done. Thanks.
Thank you, Dr. Krauss. Good evening to those of us who have joined us live, and greetings to those who may be watching this on demand after the fact. Like Dr. King said in the beginning, this is being recorded and slides are available. So using the slide that Dr. King showed, that showed us where we can access all of these talks that are recorded and on demand on the Taylor website. This will be posted there with these slides. There is almost no room for opinion when it comes to coding. There is no such thing as strategic coding. There's no such thing as what is the best way to code, fill in the blank. Most of the time, there is only what is the correct way to code, fill in the blank. And my goal tonight is to provide you with the correct resources so that you know where to go to get the correct answers. And I'll say again, almost every single time when there is a coding question, there is one correct answer that comes from a source that can be referenced. That answer normally does not come from a Google search or any other type of search engine, or my friend said, or my residency director always thought, or going on Facebook into some group and saying, how does everybody code so-and-so? That's not the right question. The question isn't how do others do it? The question is, what is the correct way to do it? And most of the time, there's one correct answer, again, from a source that can be referenced. A lot of the work that I do is helping colleagues stay out of trouble. Dr. King mentioned helping you stay out of trouble or coming to your aid when you're already in trouble from making a mistake and participating in those defense cases. I can share there typically is one source that is submissible. If it really gets bad and we're looking at a legal situation or a judge or something like that, there are sources that are acceptable and sources that are not acceptable. So we need to know where to go to get the answers. And again, my goal is to provide that information to you. I'm shooting to talk for like 25 to 30 minutes here, leaving lots of time for Q&A at the end. You're going to have both Dr. Krauss and I. That's over 50, I think, 50 plus years of coding experience and certifications and lots of Q&A time. We are going to discuss CPT codes, and anytime we do that, we must share that CPT is copyrighted by the American Medical Association and a registered trademark of the American Medical Association. Let's start with diagnosis codes and the importance of using an appropriate source for your ICD10 codes. We see too many people get denied payment or even worse, get into trouble by using inappropriate sources for their diagnosis codes. And what we see is people Google ICD-10 posterior tibial tendonitis, or they still have the ICD-9 code memorized, because some of us worked with ICD-9 for 20 plus years, and still it's almost like when somebody speaks multiple languages, you ask, what language do you think in, or what language do you dream in? There are still some of us that think primarily ICD-9 and then want to translate it, right? So we go on Google and do crosswalk the ICD-9 code to ICD-10, and that results sometimes in inappropriate information, or that Google search results in inappropriate information. And there are several reasons why we get incorrect answers. One is the ICD-10 code set changes every year. Every single year, there are additions and deletions and modifications. And every single year, there are changes that are pertinent to podiatry. If you're watching this and you're not a podiatrist, the same can be said for any specialty type. We could say there are changes every year that pertain to the practice of, and we could fill in that blank with any medical specialty there is, because there's lots of changes every year. And it's pretty much a guarantee, whatever your specialty is, there will be changes. So people get answers that are online that are outdated. And too often we see colleagues not getting paid for something. And they'll say, I always got paid by doing it this way, but now I'm not. Why? Well, that code was deleted 6 months ago. Oh, well, on this website or in this chat room or this blog, so-and-so wrote whatever. Well, all right, that was 2 years ago. The code's not valid anymore. So that's one reason. One other reason, because there's more coming, is very often those Google searches and online crosswalks result in unspecified ICD-10 codes. The reason is ICD-9, one reason. ICD-9 didn't have laterality, right? ICD-9 didn't differentiate left and right. ICD-10 does. So if you Google a crosswalk for an ICD-9 code, very often it leads to an unspecified, because we didn't put in right or left in our ICD-9 code. And it's not just laterality. And most of the time, there are some exceptions, most of the time, we should not be using unspecified ICD-10 codes. Just to give you a very simple example, we know that we have hallux valgus left, hallux valgus right, and hallux valgus unspecified. If you code hallux valgus unspecified, what you're telling them is that the documentation did not specify whether it was left or right. And the great majority of the time with us, it actually did specify left or right. So you might ask, well, why do they even exist? The reason is most of the medical world doesn't function the way that we do. If you're watching this, you have an interest in coding. You are very likely doing your own coding, as I do. However, most of the rest of the medical world doesn't function that way. Most providers provide the service, dictate a note, and they don't know anything about coding. And the note goes to a coder who might be on the other side of the country. The coder reads the note and pulls out the codes from the content of the note. So if the note talks all about a painful hallux valgus and never specifies left versus right, the coder says, well, it's not right, it's not left, it was unspecified. And they choose unspecified. But that's very rarely the case, that we don't document left versus right. So we shouldn't code unspecified if we actually specified the parameter that we're telling the payer was not specified. And that one's probably not happening, because most of us are probably pretty good. I'll tell you one that we see a lot is the L97 ulcer codes, where it is the fifth character of those L97 codes where we specify the depth of the ulcer. And so frequently we see a progress note which was good. The note was good. And the note says full thickness or down to subcutaneous tissue. But then we look at the ICD-10 code, and that fifth character says unspecified depth. So now the note tells us which foot it's on and how deep it is, but the code tells the payer that the depth was not specified in the note, and left versus right was not specified in the note. And the reason this is important is more and more third-party payers are stopping their payment of claims where unspecified diagnosis codes are used. We are now 6+ years into ICD-10, going on 7. Still, more and more payers are pushing that button, flipping the switch of saying, no more. We're not paying unspecified ICD-10 codes. This is public information. Noridian, with a Medicare contractor for 13 states in the US, Noridian is slowly, service by service, pulling the majority of unspecified diagnosis codes out of their system and building edits where, for the most part, they will not pay. And one of the Noridian medical directors told us, this was through APMA communications, why should we pay you for a service where you can't even properly document in the note and specify what should be there? And again, by coding unspecified, you're telling them the documentation was incomplete. So if you're still using those codes, stop. And if Googling or using inappropriate sources is contributing to your use of unspecified codes, stop using them. So where do we get the actual codes? These are free. This is online, free for anybody. So instead of Googling, instead of going onto Facebook to look for this stuff, go to the actual source that is current and up to date. And I'll add one more mistake before I dive into that. One more error that we see is that the coding is incomplete, right? A lot of times with ICD-10, I mentioned L97, for example. Well, that's part of diabetic foot ulcer coding, but even when you're done with that code, there are additional codes that are required. So you should be using a tool that tells you whether you're done or not. The same goes for a number of characters in the code. We see sometimes where it should be a 6-character code, but the person only uses a 5-character code because that's all they found on their Google search. So here is where ICD-10 codes are housed in the United States. ICD-10 comes from the World Health Organization. This is an international entity. Here in the US, it is governed by the CDC, and the codes we care about as providers are published by CMS. This is not a Medicare specific thing. It just happens to be published by CMS. I know it's no fun writing down a big long URL. I certainly won't read it. That makes for a terrible webinar. This is one of the reasons why I said the slides are available. I guess you can write this down, or if you're really into it, you could hold up your phone and take a picture of the screen right now, and I'll stall for a couple seconds if anybody wants to do that, and remind you that these slides are posted on the Taylor Medical website, and it will be there for you to write this down if you want. So if you go to this website, this is what you'll find. CMS websites are not user-friendly most of the time. At the end of this, I am going to show you a much more user-friendly, easy way to find ICD-10 codes. But if you really want the source where this comes from, this is where it is. If you look along the left-hand column there, you'll see that there are actually, if you don't already know this, 2 different types of ICD-10 codes. ICD-10 PCS, that deals with facility coding. That's for hospital stuff. Most of us don't care about that. ICD-10 CM, the clinical modification. Those are the codes that we care about. And you can see there they are in the left-hand column. And I said every year it changes. So just above that green arrow, there is our 2021 ICD-10 CM set. That's it. That's every single code that exists. If you click on that, this is the CMS thing. You keep clicking and clicking and clicking. If you click on that, it will bring you here. They don't make it easy, but I'm showing you what to click on. If you want to continue down this path, you would click on 2021 code tables tabular and index. That's what we're looking at there. If we click on that, then we get this download where it becomes a trial and error situation to find what you're looking for. I did it for you. If you double click on this ICD-10 index, this is every single ICD-10 code that exists in alphabetical order. It truly is an index, just like an index in the back of a textbook that we may have had in school. They're all there in alphabetical order. Also, we could choose the tabular listing. So if you know, well, I know it's M70 something, and you're searching by the code rather than the descriptor, you could search that way too. So you could use the index to look them up by an alphabetical order, or you could use the tabular listing to find the listing by code. So that's the official source for ICD-10 coding, which will always be kept up to date. The next source to focus on is the National Correct Coding Initiative Policy Manual. This is also free and online. I get asked a lot. I want to know a lot about coding. Where do I start? This is a really good place to start. Or I'm opening my own practice. I want to be really solid with coding. What can I read? This. I also hear from people, I'm in a large group. I've been assigned the role as the coding person. They're giving me 5 hours a week of admin time to check our coding. I don't know, I'm making that up, right? Where can I go to get this information? The National Correct Coding Initiative Policy Manual. There is so much meat in here. There is so much good coding content. And if you really want to get into this, and I do get asked this a lot, right? How do I know more? How do I get confident with my coding? This is an excellent place to go. So many of the questions that I answer come from the National Correct Coding Initiative Policy Manual. Most of my career is providing guidance in coding, and 25 to 50% of the answers that I provide every day, the reference is the National Correct Coding Initiative Policy Manual. And you, instead of saying, well, I read online that, or so-and-so said that, instead you can say, Chapter 2, Section G, Subsection 4 of the National Correct Coding Initiative Policy Manual says the following, right? And that's where you get this guidance. So if you're interested in finding the National Correct Coding Initiative Policy Manual, this time I'm not going to give you a big long URL to write down. If you Google NCCI, that stands for National Correct Coding Initiative. If you Google NCCI manual, this is the result that you will get. And look at that right there. There it is. NCCI policy manual. Now, if you click on that, this is what you get. Now, what did they not give us? The titles of the chapters, which is ridiculous. So the only way to know what each of these chapters is to click on the darn thing, which I find incredibly frustrating. I did it for you. If you are a podiatrist, and I realize there may be some non-podiatrists on there, but you can find your area too. If you are a podiatrist, I would suggest that these are the 5 areas that are of most interest to you, these 5 chapters. So like I said, if you go to that website, they don't give you the chapter headings. What table of contents doesn't tell you what the chapters are? It's ridiculous. But here they are. These are the ones that I suggest would be of most interest to you. It's heavy reading. It's a lot of legal terminology. There's nothing you can't understand. Nothing. But it's not casual reading. It's heavy duty stuff. But if you're into this, and you want to know more, you will enjoy this. Like I said, a lot of meat in here. I read these 5 chapters twice a year, and many of the other chapters I read once a year. It's good content, and you will find as you read this, oh my gosh, there's the real answer to that question that I've been hearing for years and years. And just an example, right? So an example of, can I do debridement and skin substitute application at the same time? Or can I do a plantar fasciitis injection and a strapping at the same time? Or Can I bill for putting on a cast if I cast the patient in the operating room after I complete a fusion procedure? These are such typical questions that you see all the time in these chat rooms and whatever else people are doing, Facebook, right? The answers are right here. So just one example, right? One example here. Can I do a strapping after an injection, right? Let's say it's plantar fasciitis. Can I code for a strapping and an injection? Is an injection a therapeutic procedure? Of course it is. It's a form of therapy for plantar fasciitis, right? So look at this. Chapter 4, Section G, subsection 2 states, and I won't read it for you, tells us that we can't. There's the reference, right? There's where, and it's not all bad stuff. Some of it's good stuff too, telling us we actually can submit two different services, right? So that's just one example. And if you read through those chapters, you'll find all kinds of stuff that applies to what you're doing in your practice every day. The ICD-10 codes are free. I showed you where they are. The NCCI policy manual is free, and I showed you where that is. I shared at the beginning of this that the American Medical Association owns CPT, and CPT is a registered trademark of the American Medical Association. They do not give it away for free. This is an especially important reason why you should not attempt to Google CPT codes, because that is actually policed, and they will take down and go after those that are publishing CPT codes. So if you find one, not only is it from an unofficial source, it's from an unofficial source that hasn't yet been taken down. So even they couldn't find it. So it's almost like, I'm not really using this term right, but it's almost like an underground internet thing that isn't even supposed to be there, right? Like if you think of a pop artist who's selling their music on a platform like iTunes, for example. If somebody were putting that up for free on the internet where we could go steal it, right? Or download it for free or something, they have people that are policing that and taking that type of content down. If you're finding CPT code listings online for free, it's kind of an equivalent situation. There is one place to get CPT codes, and that is from the American Medical Association references or a pay site which has licensed CPT codes, which is what I'm building towards. These codes change every year too. If you're relying on a book, it unfortunately should be a brand new book every year, because these change every year. There's one source for CPT coding. It's the AMA CPT book and AMA CPT assistant, which is the one source that can be referenced when it comes to CPT coding. The second to last reference that I'll talk about is the CMS Physician Fee Schedule relative value file. I'm going to provide the links and where to find it coming up. This is another source of so much meat and so much healthy coding content. This is another one that I get asked questions every single day where the answers are right there in the Physician Fee Schedule relative value file. How do I know what the global period is for this code? Is this code subject to a multiple procedure reduction? Right? You hear people say, well, you cut the second one in half and then the third one in half after that. Sometimes, not all the time. Some services are subject to a multiple procedure reduction. Some are not. You can look that up for free and see which ones are subject to multiple procedure reduction, some are not. It's another thing I see all the time. Somebody goes and does a procedure, they bring an assistant surgeon, and the assistant surgeon submits the appropriate coding and doesn't get paid. I spent all that time, I went there, I didn't get paid. Well, before you did that, did you check to see if that was eligible for assistant surgeon payment? Because some codes have that as a yes, some codes have that as a no. Seems like something you want to check before you go function as an assistant surgeon. Similarly, co-surgeon, which is different from assistant surgeon. Co-surgeon is where, let's go back. Assistant surgeon is where two people are helping each other to provide the same service, right? Like triple arthrodesis, somebody's working medial, somebody's working lateral. You're accomplishing the same thing. That's assistant surgeon. Co-surgeon is where one provider does one part of the procedure, another provider does another part of the procedure. So maybe you as the podiatrist are doing something to the foot, and an orthopedic colleague comes in to harvest bone graft from the hip. That's a co-surgeon. Some services allow for co-surgeon payment, some do not. Technical component, professional component. Can this imaging service, a lot of us are familiar with this with x-rays, be broken down into a technical component or a professional component? All of those answers. RVUs, if you're working for a facility, the listing of the RVUs, all of those answers are in the CMS Physician Fee Schedule relative value file. It's a big giant Excel document. You download it once a year, because it does change every year. You download it once a year. This is what I do. I would suggest if you're into this stuff, you do the same. Lives on your desktop, and there it is for the whole year. And it's just a listing of the codes in numerical order. You scroll down to the CPT code that's in question, and you'll find all the RVUs, facility, non-facility, total, work, whatever you're looking for, global period, and on and on and on. And there's more even than what's listed here. This is just some example. Straight across, right, left to right in that Excel document, everything you could possibly want to know for that code. So if you want to find that, this is another Google. If you look in the search box there, I'm going to move our video over to the side here. If you look in the search box there, what you'll see is I've gone to Google. I did not try it on other internet search engines. I imagine the results are the same, especially for this. If you do a Google search for the current year, if you're watching this 2 years from now on demand, of course, put in whatever year it is, the current year that's of interest, space RVU, space file. The first match is what you see here. And you would click on that first match. Fortunately, we only have one file to download. That's awesome. And if we click on that, it gives you that Excel document that I was talking about with all of that information. The majority of what I just shared with you is free and available online. However, the majority of what I just shared for you also is not user-friendly, difficult to navigate, and following all of those different links and clicks and downloads that I talked about. If you're interested, there is an excellent online resource which brings everything I just talked about together into one place, and that is the APMA Coding Resource Center. Remember what I said, that AMA owns CPT? And if you want to republish or share or copy and paste CPT codes, you have to pay for that. So there, of course, are CPT codes on the APMA Coding Resource Center. And I've heard it asked, why doesn't APMA just give this to the members as a member benefit? AMA makes APMA pay to list, and that, not just APMA, any entity. APMA makes those who AMA requires those that share CPT codes to pay for that. And that's why there has to be some charge associated with this. There is a significant member discount. You don't have to be an APMA member to get the Coding Resource Center. However, if you are, the discount almost pays for your membership, especially if you get a 3-year subscription. You can learn more about this at apmacodingrc.org. That's RC stands for Resource Center. And just one slide, not going to do a whole tour here. If you go there, there is a video tour. And just looking across the top there, if you look at that CPT tab, if you were to click on that, that narrows down the listing of CPT codes to those that are pertinent to podiatry only. So you're not fishing through the entire CPT book. Look how thick this thing is if you don't have one on your desk. If you click on CPT here, it will give you podiatry pertinent CPT codes only. And then under every code is everything that's in that RVU file. It's global period, it's RVUs, it's bilateral indicator, assistant surgeon indicator, right? All that stuff. And people really like this. For the CPT codes, there is, for most of them on there, a list of suggested ICD-10 codes to consider using when submitting that CPT code. So it happens a lot that you might find your CPT code and then say, well, I know what I did. I know what my CPT code is, but what's a good ICD-10 code to consider using here? Using this tool, under every CPT code, there's a list of suggested ICD-10 codes. If you click on that ICD-10 link, one option is the entire 75,000 plus listing of ICD-10 codes, but another option is podiatry relevant only ICD-10 codes in alphabetical order. The most commonly used ICD-10 codes by podiatrists makes it much easier. And we are prompted to choose laterality, choose appropriate specificity, get the proper number of characters, and if more than one code is needed, it will tell you that, right? I mentioned the diabetic foot ulcer coding. It's not just one ICD-10 code. This will give you that guidance. HCPCS code lists HCPCS code options. If you look at the CCI edits, you can enter 2 codes and it will tell you whether they are bundled or not. The official terminology is whether they are paired or not. And if they are, and it is appropriate to use a modifier, which code the modifier should be placed on. If you look at the Medicare tab there, it lists your state's local coverage determinations. We hear all the time, I don't know where to find this stuff, or how am I expected to know all this? If you click Medicare, you get a drop-down menu. You click your state, and filtered there is your state's coverage determinations. For example, if you click on your state and you click on that state's routine foot care policy, gives you every single thing that needs to be there. Skin substitute applications. 5 out of the 7 Medicare contractors in the country have skin substitute policies where it pretty much gives us a checkbox of everything that needs to be there. In the case of an audit or review by a third-party payer, they're giving us the answers to the test. We just have to read it. There's more there, as you can see. There's MIPS content. There's lots of other references. There is a legitimate crosswalk where you can put in the ICD-9 code and it will crosswalk it to ICD-10 for you. So we provided the official resources for you to look this content up for ICD-10, HCPCS coding, CPT coding. We talked about the National Correct Coding Initiative Policy Manual, and finally, the Physician Fee Schedule RVU Final, where you can find so many of the questions that are commonly asked and questions that you may very well be looking for the answers to. And there is the option of the APMA Coding Resource Center, which brings all of that together in a very clean, neat, user-friendly place. And I should have mentioned, it is also mobile friendly. So no buying books every year, no carrying around heavy books, no being at one office and saying, the book's at the other office. It's in your pocket, on your phone, no matter where you go, in a nursing home, in the hospital, in the operating room, you have that coding reference in your pocket. And it's a tool I would suggest you consider. Thanks for your attention. We kept our promise of allowing 21 minutes, actually, for Q&A. So we'll welcome Dr. Krauss back in, and please don't be bashful with your questions. We hope you'll be generous with any questions that you might have. If nobody has typed any in yet, I have a couple to prime the pump, and we'll transition it back to Dr. Krauss here.
Well, Jeff, can you hear me?
Yes.
So, you had so many good points, and you talked about so many different things. And, I think about what I see all the time. And I'll tell you what was really interesting when you talked about even the L97 codes and the unspecified. Believe it or not, I see a lot of claims where the doctors just put E1 1.621 and they think that's good enough. They don't even understand, or people don't understand, the nuances of codes having to be paired together And then once they understand that concept, appropriately choosing the right code when they pair it. So I don't know what your thoughts are on that, but that is a very common problem that I see as well.
You said it. You said it. I gave the example of some pathologies require more than one code to represent that pathology. And Dr. Krauss provided us with an excellent example, which is diabetic foot ulcer. He gave the example of E11.621, which if you look up E11.621, it says type 2 diabetes with foot ulcer. Well, that sounds like all we need, but it's not. Because if you're using an appropriate tool, you will see that along with that listing of E11.621, it says use additional code, and those are magic words. Those words mean something. Use additional code to identify the site or location, I don't remember the exact word, of the ulcer, and that's an L97 code. And when it says ICD-10 language, when it says use additional code, if one of those options is appropriate, which in this case it is, we must use that code to complete the coding. Furthermore, when it says use additional code, the order matters. Sometimes which one you put first or second doesn't matter. When it says use additional code, that additional code must come second, following. So Dr. Krauss, I've seen the same where people put E11.621 only and it doesn't pay. Or what's even scarier in some cases is they've been doing it that way for years. And then all of a sudden, because the payer says, you know what, we're 5 years into ICD-10 now. It's time for them to start doing this right. They'll push a button that enforces what we should have been doing the whole time. And all of a sudden we're not getting paid. And sometimes practices go months before they even figure this out. And then it's a mess. Because they first have to figure out what the problem was, then they have to go back and they have hundreds of claims that were denied. Important to use the right tools so that doesn't happen to you. And I'll say again, these payers, as the years go on, are pushing that button.
They're getting more sophisticated. They realize, you know, the biggest reason that we have, in my opinion, the biggest reason we have denials and issues getting paid is the lack of knowledge. And you hit the nail on the head of the physicians that are doing their own work. And no offense, sometimes the staff isn't conveying all the messages appropriately on what needs to be done. And I can also tell you, Jeff, just staying in that, and I won't stay in this wound care family, but I do have a few comments that I think are things that I see frequently. The other thing is people think they can use the L97 code, and that implies because there's an ulcer that they're diabetic. Well, that's not the case. Particularly if you're doing biologics or doing other things and you have to treat those patients, and the primary reason that they're getting paid is because you have diabetes, and the secondary reason is the actual location of the ulcer and the ulcer that's being said. I see that as a huge problem as well. And I think that I know that you and I and many of the people on the APMA coding team have lectured about this ad infinitum. But yet I have seen it pop up over and over again on even audits that I'm involved
in. Very much agree. And using that L97 as an example, it goes both ways. If you look up E11.621, it will say use additional code, like I said. If you looked up L97 using an appropriate source, it will say code first.
The systemic condition, whatever it is, whether it's a vascular systemic condition, a diabetic. But again, you and I know this language, and I'm asking these questions, even though you and I both know the answers, because these are the common problems that we're seeing. I actually have a question that came up here. I'm going to just read it to you. It's from one of our dear friends on the coding committee. Do you see the question that has popped up?
Yes.
You want to take it or you want me to take it? You take it. You're the guest.
Okay. I'm going to read this. Even if we are coding or we have staff doing billing, so billing and coding are two totally different things. So maybe the questioner meant coding. I don't know. Should we not be coding or submitting claims based on what's been documented, even if it means we need to amend the note before claims are filed, so we support claims based on documentation. I don't understand the question.
So I'm going to take a stab at it, Jeff. I think what she's asking is that much of the billing and coding that we do should be based on the medical necessity of the documentation. And I think that I can tell you that for me, when I was doing billing and coding for extremity healthcare on all of the wound care and biologics, I would read every code, every documentation to make sure that the note met the standards for medical necessity before the claim was filed, so that we would be able to make sure that the claim met medical necessity. I think that's what Barbara's asking, and I would venture to say that I don't think anybody has time to look at every single claim to make sure that every bit of medical necessity matches what they're doing. I recommend doing it on high dollar reimbursement areas: wound care products, wound supplies, DME, hospital surgical coding. Those are the areas where I think, for my personal recommendation, would be working on those niche areas. It's too much to read 30 at-risk foot care notes a day and make sure. Hopefully, after all this time, you know what you're doing, and hopefully you won't be getting in trouble. But I think Barbara's point is you would want to make sure that the documentation, the coding should be based on the level of documentation, because that's what's going to protect you.
Yeah, I thank you. I think I understand it better now. So yes, you should document exactly what was done and then code what has been documented. And it's important that the document, I think I'm saying the same thing Dr. Krauss just said, but a little differently. The documentation must support the coding. So if you code type 2 diabetic foot ulcer, right forefoot, the documentation should contain all of those things. And it goes the other way. If you've documented that something, it should be coded as well, right? If you've documented something that played a role in the visit that day, if you've documented something that played a role in your decision making, played a role in what you did, it should be coded. So you could have incorrect coding because the documentation didn't submit what was coded. Vice versa can occur.
Correct.
Also.
Correct. Jeff, I'm going to ask you a question that you know that I have personally struggled with recently. And, I defer to you about certain things, and your response to me was great, and it makes complete sense. But I guess what would the general public think? Jeff and I sent an email to Jeff because periodically, as I'm doing work and I review the APMA Coding Resource Center, if I find mistakes, I forward them to Jeff because he is the keeper of the sacred portal. And so I recently found some ICD9 conversions that weren't changed to ICD10. And I was actually doing a webinar for a young physician talking about wound care. And I made the comment that when you're treating a patient and you're in an operating room setting, or any setting, an office setting or an operating room setting, that you would not be debriding a wound on the same day that you're applying a graft to that particular wound. But if you go into the Coding Resource Center and you'll see where there are indicator codes, 0, 1, or 9. 0 meaning I believe it should never be billed. 1 meaning it could be billed if appropriately is the word somewhere. And 9 is, I forget. The problem that's confusing is, unfortunately, what happens is when people are looking at that, it doesn't say if you're debriding one wound and applying a graft to another wound. What people see is, oh, I could put a 59 modifier on and get paid, and I can debride a wound the same day I put a biological dressing on. Jeff, can you explain how the layman or a new coder or a naive person would be looking at that, and how would they get the right rules? Am I making sense in my question?
Perfectly. So what we're talking about is the National Correct Coding Initiative edits. And really, this answers, how do I know if I'm unbundling or not? How do I know if I can submit code A and code B? And the answer to that is found in the National Correct Coding Initiative edits. So if you have a good tool like the APMA Coding Resource Center, and you say, I have CPT code A and CPT code B. I did both of those. Can I submit both codes? The way you find that answer is you put both codes in, you push go, and then it tells you whether those codes are paired or not. Here's a really good example that I hope everybody knows. If you do a bunionectomy procedure, you can't also code for a capsulotomy, right? Because we had to do the first MPJ capsulotomy in order to do the bunionectomy. So let's use that one as our example. So we say, I did a right foot bunionectomy, and as part of that bunionectomy, I did a capsulotomy. We could do the same thing for extensor hallucis brevis tenotomy, right? But let's just do capsulotomy because it's really simple. We put those two codes in. Are they paired? Well, the first thing is, if they're not paired, it's over. There's nothing more to talk about. Yes, you can submit both. The two I gave in my example, of course they are paired. So we say, okay, they are paired, but we're not done. Because like Dr. Krauss said, not only do we have to look at their pairing, but we have to look at the indicator that accompanies that pairing. I'll say that again. Are they paired? No, we're done. Yes, they're paired. The next question is, what is the indicator that accompanies that pairing? If the indicator is 0, it means they can never be submitted at the same time ever under any circumstance. If the indicator is 1, it says you can submit both of those if, this is a huge if there is an appropriate modifier that represents the services that were performed. So when we talk about a bunionectomy and a capsulotomy, first MPJ capsulotomy, what is the only potential modifier that we could use there? 59 or an X, right? 59 or an X modifier, indicating that these were separate structure, separate site, separate procedure. That's what's in the 59 modifier descriptor, right? So the one indicator says you can submit both if, big if there's an appropriate modifier that can be used. So if we did right foot bunionectomy, and as part of that, we did right first MPJ capsulotomy, is there an appropriate modifier? No. 59 modifier doesn't work because these were not separate procedures at separate sites, separate lesions. They weren't. It's the same thing, right? Now, what if we did a left bunionectomy and a right first MPJ capsulotomy? We should be able to get paid for that, right? So if we did left bunionectomy, right first MPJ capsulotomy, we'd put those two codes in and say, oh, they're paired. However, they're paired with an indicator of 1, telling us that we can submit both if there's an appropriate modifier. Is there an appropriate modifier? Absolutely, right? 59 or X, depending on who the payer is an appropriate modifier. And just to finish this, Ira mentioned the final indicator option of 9 tells us that pairing is expired and is no longer active. So if you see a 9, they're not paired either.
Hey Jeff, if I maybe I misunderstood. How does one understand if the code is applicable? I guess my point is, if I debrided an ulcer on my left foot and did a graft on the right foot, I understand that that's appropriate. But you know, when people read these quickly, what it reads, the way you read it, it said this is payable if it is appropriate to apply the modifier. Obviously, the key word there is appropriate, and I think that it's very deceiving because there are a lot of people that will say, well, for example, in that case, the wound was really infected. It really needed to be debrided. My comment is, well, if you're doing a biologic, you're not supposed to put it on an infected wound because that's what the package label says for clinical indications. But my point is, and I don't want to beat a dead horse, I know it's an issue and a problem, and I think people need to understand that that word appropriate means it needs to be medically necessary for you to be doing those procedures, correct?
Yeah, and be careful, so in order to determine if the modifier is appropriate, read the description of the modifier you are considering. So if you read the 59 modifier, I should have pulled it up here. If you read the descriptor, right, the actual definition of the 59 modifier, and this is where you might have to slow down. It says distinct procedural services. Different session, different procedure, different surgery, different site, separate incision, separate lesion, or separate injury. So if you're asking yourself, is it appropriate to use the 59 modifier here? You have to read that and say, does my situation match any of those? If it does, it is appropriate to use the modifier. If it does not, it is not appropriate to use the modifier.
Great. So I have another question here. How would you code a brachiometatarsal surgery on a 3rd and 4th met right with application of an external fixator for each metatarsal? I'm assuming that a lengthening osteotomy was done. I'm assuming the code would be an osteotomy of each metatarsal with application of an external fixator, with an application of an external fixator code.
Okay, so this is, this is going to bring together a lot of what we talked about. So first, let's find the diagnosis. I went to the APMA Coding Resource Center here. I clicked on the ICD10 tab, which puts the most commonly used ICD10 codes for podiatry in alphabetical order. I scroll down to the B's, and here I'm looking at brachiometatarsal, which is Q74.8. Q74.8 is brachiometatarsal. We do not need laterality with that one, so that's good. We don't have to worry about left or right. So that's your diagnosis code. Now, I clicked on the CPT tab. I'm scrolling down to musculoskeletal foot, and we're going to look for osteotomy. Is it central metatarsal or just metatarsal? I think I have it. I think it's 283. Well, let me not guess. Okay, here we go. So our osteotomy code is CPT 28308. 28308. We're sharing this for educational purposes, having shared the reference that the source for this information is the AMA CPT 2021 book. 28308 is osteotomy metatarsal other than first metatarsal. But we're not done because an external fixator was applied to this. So now I'm going to got another CPT code coming. I've gone to the general musculoskeletal section, and I know that there's a couple different codes for external fixator depending on which type you use. So here we have application of a uniplane, unilateral external fixator, application of a multiplane, like Elizarov option. So for brachiomet, I'm sure this was CPT 20690. CPT 20690. Application of a uniplane, unilateral external fixation system. But are we done? All right, now this is now level 2 coding. We have 2 CPT codes. Can we submit both? Can we code for the osteotomy and the external fixator? How do we find the answer? We need the National Correct Coding Initiative edits. So now let's go to the edits, and we'll put in 20690 and 28308. And I'm going to hit go, and it's going to tell me whether these are paired or not, and if they are paired, what the indicator is. They are not paired. Therefore, you can submit both CPT 20690 and 28308, And this said the identical procedure was performed on 2 adjacent metatarsals. So I would suggest submitting both, 2 units for each. And that's your complete coding for the procedure that was submitted.
That's exactly what I would have done, Dr. Lehrman. You are a true genius. Anyway, you know, it's 7 o'clock, and I think that it's always really a pleasure to have, you know, Jeff talk. We work together on CPT. We've worked together lecturing and coding all over the country. He is a go-to person in our profession, not only within the profession of the Podiatric Medical Association, but with other people who look at his skills and health policy and practice. So again, it was really an honor, you know, having you here and having the ability to let you talk to our Taylor members. I think for me, the big take home when I think about closing all of this up is there are rules and regulations to follow. And if you understand the guidelines and you understand the rules, you're going to do very, very well. If you leave it in the hands of other people without knowing the rules and regulations, I think that's when you're going to struggle. It doesn't mean you have to be a do it all by yourself. I think what it means is you need to appropriately invest in your staff if you're going to have staff do your billing and coding. You need to send them to programs. You need to get them trained. Otherwise, you're going to be getting on this webinar with Jeff every 3 months, and you're going to hear the same stuff over and over again. And the reality is you're going to get on a hamster wheel unless you get yourself taken care of. I will tell you that I want to go on and again, thank everybody who came on. Our next lecture is actually a very interesting and controversial topic that's going on in the world right now with amniotic fluid injections. There are still products that are being used because the vendors themselves have determined that they have met the criteria for a BLA. So we will be seeing Dr. Richard Silverstein talking on amniotic fluid injections for musculoskeletal conditions with clinical pearls and billing questions. I think it would be very interesting for those of you who have been confused about what's going on in this very, very controversial space. With that being said, we've gone 3 minutes over. Jeff, I'm looking forward to seeing you in a couple of weeks in Tennessee. I'm sorry that you're blowing me off in Denver, but I understand your kids come first. And I'm sure we'll be speaking as we prepare for our CPT meeting as well. So anyway, everybody, I want to thank you very much for joining us. Please try and make Taylor your go-to group. Give us the opportunity to see if we can meet your practice's needs. That's all we ask at Taylor Medical. And the thing that we also offer is we don't just want to sell you the best widget. We want to teach you how to use that widget. And having people like Dr. Lehrman and Dr. King on our board helps us complete this mission. So again, to everybody who joined us on Rosh Hashanah, Lashana Tova, and look forward to seeing everybody in 2 weeks. Jeff, thank you very much again.
Good night.
Good night, everybody.